Welcome to episode 2 of the Expert Interviews series. Today's guest is Dr. Bruce Patterson. We're going to talk about his latest research results which suggest that residual viral protein is responsible for triggering long haulers' symptoms and just what the implications of that might be for treatment and recovery. Once his preprint is released, I'll be adding that to the description. Enjoy. So thanks so much for joining me, Bruce. You've been doing some great work in this sphere. I think a lot of long haulers are very excited about the work you've been doing, starting with the index that you created and the machine learning in your first paper you published and the research you've been doing more recently. But before we dive into that, for the people who don't know who you are, can you just give us a brief overview of your background?
Sure. I'm Bruce Patterson. I'm a pathologist by trade, and then I went on to do a fellowship in molecular virology, which obviously integrated the immunology of HIV at the time. I started doing research on HIV in 1989. So this is about my fourth pandemic. So I'm not surprised by any of the things that are happening. I think with viruses that mutate like SARS-CoV-2 does, we predicted a year ago that we were going to have issues related to variants. And so, I went on to do basic science research in virology at Northwestern, and later was the head of diagnostic virology, clinical virology at Stanford, and continued my research there. And then we founded IncellDX to bring these technologies to the masses, around 2010. And that's really what we do is we do R&D and discovery to really determine what we need to be able to do precision medicine like we're doing right now, where we're using very sophisticated diagnostics to drive how we treat patients rationally. Our mantra is not to use patients as a guinea pig and try this and try that and see what sticks. Our mantra really is to get to the heart of the mechanism and then start to use drugs that target the pathogenic mechanism and treat the cause rather than treat the symptoms. And that's right where we are right now in the battle against long COVID.
So could you tell me a little bit about your recent research that sheds light on what might be causing some of these long COVID symptoms?
Well, like you said in our first paper, which involved machine learning in looking at differences between acute COVID and long haulers, which we started doing summer of 2020. It was really reassuring, I think, to patients to know that, hey, something really drastic is going on. I think they were met, you were met, everyone, long haulers were met with, skepticism when they went to their primary care physicians, and they're being brushed off as being post-traumatic stress disorder after having active COVID, and maybe it's in your head or it's anxiety or whatever. And the fact is, I'll tell you, half the battle of the road to recovery for long haulers was understanding that there's something very real going on, and then that helped us identify that this was a very distinct immunologic entity. We also found evidence. We looked at over 150 biomarkers to start. We narrowed that down to maybe 14, and maybe that's growing a bit now with some of our recent discoveries. But the fact is, we started to see patterns that were suggestive of vascular inflammation. That went into our first paper. And then there was also suggestions that this was being driven by persistent COVID. We published a paper in November showing that we could find COVID RNA out to 87 days in a patient with low CD8s. And really, to our surprise, in patients who are long haulers, 25% still have low CD8 counts after acute COVID infection. And of course, we've gone on to now in our recent paper, like as you suggested, found COVID antigen in circulating monocytes out to 15 months. And this population of monocytes really patrols the blood vessels throughout the body, including being able to go through the blood-brain barrier and cause inflammation of the blood vessels. And we use two drugs, CCR5 antagonist, to keep these cells from basically mobilizing around the body. And then another drug class called statins, which are cholesterol drugs that interfere with the pathway that draws these cells carrying COVID antigen and causing inflammation into the endothelial cells, which is the lining of the blood vessels, and causing blood vessel inflammation all over the body. You know, this mechanism is so useful because it really helps us to explain why the symptoms are so widespread and so varied and all around the body. I mean, there's several reports that there's persistent virus, you know, here, there, the gut, other places, which is true. But this is the first discovery and mechanism that shows that a cell type that is capable of carrying this protein throughout the body and causing inflammation is at play. And it's not just in one organ or another organ.
So do you think that, like, where is it picking this? These monocytes are going around basically, so we spoke about this before, sort of they're trash collectors. They go around basically scooping up stuff from all over the place. So where are they getting these spike proteins from? Do you think that they're coming from somewhere where there is active replicating virus, or is this simply debris left from the original infection that is still being cleared out?
Right, that's a great question. And I think, you know, it was really answered by what led us to long haulers anyway, which was when we looked at patients at 28 days, 40 days, 60 days, you know, they were out of the hospital, they were out of harm's way, they were getting better, but by no stretch of the imagination was their immune system normal, not even close to being normal, frankly. And, you know, that was a big tip off that something was going on, something was persisting. That was causing an ongoing, essentially antiviral immune response. In fact, you know, the antiviral immune response in long COVID is quite appropriate if you look at the nature of the immune response. There's some differences, obviously, the vascular inflammation component, and I'll talk about that in a minute as it relates to post-vaccine symptoms that resemble long COVID, but you know, we were seeing, you know, this immune abnormalities in people who, you know, were home, who had recovered. And, you know, in our, you know, first paper, which should be in print soon, we really make the conclusion that there was, you know, a number of patients who with severe COVID who registered on the long hauler index, which brought the specificity of our long hauler index down to, you know, the low 90s, even though the sensitivity was 98, 99%. But in fact, it was very real. It was a caveat. And what we concluded was maybe these weren't false positives on the long hauler index, but were in fact patients with severe COVID disease who had a signature that looked like long haulers, you know, when they were being discharged at 28 days or 40 days or whatever they were from the hospital. So that long haulerism, if you will, was being established during the acute phase.
And so do you think that this persistence, you know, these monocytes carrying around these proteins, do you think that this is something that is specific just to the long haulers, or do you think that people who have recovered still have this going on too, but their immune systems and their bodies aren't reacting to it? Because there's some evidence that people who already have certain immune type conditions or atopy and things like this are more, or prior post-viral fatigue are more likely to basically become long haulers. So is it that their immune systems are reacting whilst other people's are not? Or is it just that the long haulers are the only ones experiencing this protracted proteins being cycled around the body?
Well, I mean, that's such a great question. And that's, I mean, sorting through all of that is going to take some time. I mean, now that we've identified what we believe is the mechanism of patients being long haulers, I think the next question is why, and why in only certain people. And I think we're starting to get some evidence in both of our papers where we compared long haulers to severe patients and to mild to moderate patients, and started to see some indications of why they may become long haulers. In other words, we were seeing the establishment of a viral reservoir in monocytic lineage cells during acute COVID. They just happen to be RNA positive and protein positive, and most of the long haulers are just protein positive without RNA, which is part and parcel to the fact that these cells are scavengers. They're scavenging, dying off cells that were infected by COVID. They're then taking those foreign proteins and expressing those, but the virus really isn't replication competent, at least as far as we know right now. We're actually extending our study and our strategy, because now we're able to isolate the cells out of long haulers that actually carry COVID protein. And then what we're doing in the next paper, in the next set of experiments, is we're sorting those cells that are protein positive and doing a very deep dive using next-gen sequencing into those cells to look at the fragments. And we have an algorithm that can predict from the fragment analysis whether or not the virus is replication competent. So I think that's a big question. But back to your original question, I think it's really key that we look at how, what was the nature of these patients during acute COVID, and what are the possible signs that, other than this, viral reservoir and monocytes, are there other signs that tip us off to the fact that they may become long haulers? I'm intrigued because now that we've looked at thousands and thousands of long haulers, many of them are between this February to June 2020 timeframe. Very few pop up in October, November. We have a couple from December and January. I mean, that's the beauty of having probably the largest cohort of long haulers in the world, is being able to look at some of the demographic elements of these patients. And like I said, it's becoming very apparent that I would say 80% of the patients enrolled in our program, and we don't know if that's just because they've had it for so long, or they're sick, or they're out of options, but they're really coming from that February to June 2020 timeframe. And so we'll look back and see what was going on at the time in terms of treatment of their acute infection. And of course, many of them were either asymptomatic or had mild disease. So we don't know much about what strategies were deployed in those individuals.
I mean, that is fairly consistent across my research as well, that most long haulers seem to come from that first wave. And there's a few reasons why that could be. Is it something to do with the original wild type of the original variants? Did that for some reason be more likely leading to long haul? Was it an increased viral load because no one was wearing masks at the time? Was it simply just the volume of people infected then because there was no testing? So big questions. Very fascinated to hear what the answers might be. But
I mean, you just brought up some of the big questions that need to be answered, and that was spot on in terms of, what are the questions that remain relative to that time frame. And I think it's a great question. I mean, I was fascinated. There's a recent report of they looked at an individual with HIV, and they looked at that individual over time. And over a period of time in the same individual, there was 32 different mutations that occurred in that individual. I mean, we're talking about mutation rates that resembled HIV. I remember back in the day with HIV, if you took a patient's blood at day one and sequenced their HIV, and then you sequenced their HIV 18 months later, it would have less than 50% similarity with what the original isolate was. So you may be onto something in terms of, the evolution of the sequence variants and whether or not some, predisposed to, being a long hauler better than other ones. And that could be all about tropism. And tropism is a word we use in virology for their ability to infect certain cell types. And cell types like monocytes that have been shown in HIV, hepatitis C by our group, and dengue fever and Zika to carry virus for longer periods of time following disease resolution.
Yeah, very, very interesting.
And there's a very interesting phenomenon in Lyme disease and Borrelia, which is a bacteria as opposed to a virus. But there are pieces of the cell membrane of the bacteria that remain in the blood for months, if not years. They get scavenged by monocytes and macrophages and hang around for a long period of time. So, we're starting to branch out to look at some of these other similar diseases. I would not, a lot of people are trying to lump them together. And yes, there's a lot of similarities, but the pathogenesis could be different, albeit there are some similarities in terms of the strategies of persistent antigenic stimulation.
I don't know if you've seen, there was an article, a paper published very recently on the BMJ Gut Journal. The date on that is, I'm just looking at it now. Have you seen it? I think they had 5 people. Yeah. Is there anything is there anything you can say about that in terms of how that sort of tallies up with your findings?
Well, what's interesting, again, when I referred to kind of a static finding versus a cell type that is highly, highly mobile. And in fact, if you look in the exercise literature, this cell type that we found, COVID protein, is mobilized by exercise. And so we tell all of our long haulers that, exercise, the reason they have exercise intolerance and feel or become bedridden for a day or two or a week after, they give it a go, so to speak, in terms of exercise, is because these cells mobilize on exercise. And then of course you're spreading them around the body and the inflammation can resume. And so, but I do think, it's consistent with what we had published in November that, there is persistence. There's no doubt there's persistence, but we took it one step further and really explained why the persistence is contributing to a certain spectrum of symptoms, and how understanding the persistence allows us to come up with effective therapies. But the gut is always fascinating, even in HIV, because it harbors 98% of our immune cells. So it's not surprising to me that that when you're looking for a virus, one of my go-to is always, let's look in the monocyte lineage. Second to that is let's go look at the gut, because that's where, besides the lymph nodes and lymphoid system, tonsils are another good place to look. But certainly the gut is a stellar place to look for persisting virus.
It's interesting. When I did a survey probably about this time last year, actually, maybe a little bit later, and I asked people about their presentations during acute COVID. Was it the sort of the conventional, if you like, cough, fever, loss of taste and smell, or was it basically nausea, GI symptoms, chills? And more people had the nausea, GI system and the chills, that presentation, than the traditional cough, fever, and in terms of who went on to develop long COVID symptoms. And I was one of them. So it does seem that the gut does play a significant role here,
Absolutely. And I think, like I said, it's part and parcel to the fact that, there's so many immune cells there, and what's happening is the antigens are being presented to the immune system, in the gut, and you're getting an immune response in the gut. And so you have this feeling of fullness or or even nausea and other symptoms. That doesn't surprise me. And in fact, in the first trials of the human papillomavirus vaccine, the 9-valent, there was such a vigorous immune response against it that the one big side effect, which I found very interesting for a viral vaccine, was gut issues. Couldn't eat, fullness in the gut, kind of nausea, which you would think, you would have more lymph nodes, swollen lymph nodes, maybe some fullness in your armpits and in your in your neck chains and some other lymph node chains. But in fact, it was very the side effects, which weren't dangerous, but the side effects were sort of this nausea and a feeling of fullness. So I think, this is very similar to, what we're seeing when you have a massive presentation of virus to the immune system.
I'm just going to ask you a couple of questions that you may or may not have a take on. And the first of them is, there's been some research suggesting autoantibodies are part of the puzzle here. Is there anything that your research has shown or anything that makes sense to you about that? And where do you stand on that subject?
Mm-hmm. Well, for now, I'm taking them with a grain of salt. Being a pathologist, I'm always looking for two things: cause and effect. Okay, is number one. Or were these autoantibodies present, before they had COVID, and we just weren't looking at this amazingly diverse spectrum of autoantibodies. That's number one. Number two, when people are inflamed from the laboratory perspective, which is, my training, there's a high degree of false positives because everything sticks. So when you're trying to do an assay in a plastic plate, things tend to stick. And so there's been in fact, we have several patients who had autoantibodies one time. I told them to get a repeat. They got a repeat and it was negative. So I'm not saying that it doesn't happen. I just think we have to be very cautious about how to interpret those right now until there's more cause and effect relationships.
And so my next question is regarding sort of serotonin levels being all over the place, serotonin imbalance, and also hormones as well, and the degree to which female long haulers seem to have, almost universally, it seems they have an incredible rash of symptoms that comes along monthly. Is there anything, again, that you can talk to about that?
Yeah, I mean, again, we haven't started to fully look into the role of hormones and other, mediators and how it contributes to the vascular inflammation that we've seen. But, it's clear that the hormones involved in the menstrual cycle, and we looked at this extensively in HIV too. I mean, some are pro-inflammatory, some are immunosuppressive because basically the body's preparing for implantation of an embryo. So you don't want this massive immune response against a fertilized egg, which is essentially a foreign body because it contains male DNA. And so, yes, absolutely, the progesterone and estrogen play a significant role in immunology and vice versa. And we used to do that a lot since I studied the transmission of HIV from mother to baby, and seeing the ebb and flow of not only hormones, but also cytokines. The cytokines IL-4 and IL-10, type 2 cytokines, which are more immunosuppressive, tend to predominate when you're trying to promote fetal implantation and eventually development of a fetus. And, it's really a cytokine switch where you have potential for spontaneous abortions because of infections. And so the placenta, which I studied for years and years and years, is such an amazing organ. And but there's definitely an influence of the maternal hormones on your immune system, especially localized.
So moving on to treatment, I know you have like a multi-pronged sort of approach to treatment. I was wondering if you could just talk a little bit about that and the mechanisms of action that these treatments have and what you're actually trying to do to actually intervene and sort of stop this sort of cycle that's happening in the body.
Well, again, a lot of it came out of the data that was in our first paper, and the bottom line was what can we do now that we're starting to understand what the mechanism is, and obviously a lot of the inflammatory immune profiles, was to use a multi-pronged approach to basically address what the data was telling us, which was, the blood vessels are inflamed. You have these other cytokines and chemokines that are elevated. And we knew drugs from previous studies that would take care of that. For instance, in our initial studies on acute COVID with CCR5 antagonists, we knew that it lowered RANTES, it lowered VEGF, it lowered TNF alpha, it lowered interleukin 6. And those are 4 of the 14 that are in our panel. So that when we see that pattern, it's like, hey, I know a drug that'll take care of all of those. And then along the way, we see when we see that cytokine pattern, and we see what drugs will relieve that or normalize that, and then we see what symptoms improve with that. I mean, that's the whole ballgame. That's what we all want to know. We want to be able to go from symptoms to improvement, and in the middle of that is, okay, what cytokines are causing the symptoms and what drugs are altering the cytokines causing the symptoms. So our 6 months of treating individuals has really led to that knowledge base. And again, for instance, if you look at brain fog and tinnitus, which is the ringing in the ears, the CCR5 antagonist, Maraviroc, has been incredible in terms of relieving tinnitus and brain fog, and then VEGF as well, which also causes peripheral neuropathic changes, and then combining it with ivermectin for a number of reasons. Number one, there was still persistent viral replication somewhere, like i.e. the gut. We would have some coverage of that. And then also ivermectin has immune modulatory effects as well, and affects cell membranes and such. And then last, what we've recently started using a lot of, which are the statins, which are, for cholesterol, but frankly, these cells that we found contain COVID that patrol the vasculature and cause inflammation, this all can be inhibited, that pathway with it, which is through a protein called fractalkine, can be interrupted with statins. So that's been our strategic approach, again, driven by data and driven by our discoveries on the pathways involved in long COVID.
And how do you see treatment working in sort of the longer term? Is this something that basically manages the symptoms, and you simply take it until your body has managed to remove whatever spike proteins are left floating around? Or is this actually do you see what I mean? Like, is this something that helps you manage it for the moment and helps you to live your life, and you simply have to wait for the body to get better? Or is this something that can actually stop the cause of the symptoms at their roots?
Yeah.
And how do you go forward?
And again, it's the latter that we've always been motivated by, which is stopping the cause. And we've been following, I would say, 10 to 15 patients serially in terms of the number of cells containing COVID. And we're finding that, some of our drug regimens are reducing the number of cells containing COVID. And so we know we're changing the root cause of these symptoms as opposed to just treating the symptoms. I mean, I think there's been some outrageous claims of using opioids on some people, and I'm like, it makes everybody feel better, right? So that's not our job, really, not to mention, replacing one, danger with another. So yes, we are directing our therapies towards removing the inciting agent, and that being persistent antigen expression. And these cells do have a lifespan. The normal lifespan may be very different than the lifespan of these cells in a pathologic condition. It's not clear from our work or in the literature what that lifespan would be if they continue to contain and present antigen. But a normal lifespan, if there was nothing else going on, should be on a matter of days or weeks. So I think, I think our goal is to expedite the elimination of these cells.
So a couple of questions left, that's all right. The first one is, what role do you see steroids have in treatment, if any? So prednisolone, drugs like that, for example.
Well, I think, from way back in September 2020, when we first came up with the algorithm and the panel, and we started treating, what we were seeing is a lot of doctors were giving some of these individuals very high dose steroids with a taper, and nobody did well on those. And frankly, they felt worse because of the high dose steroids than probably their long COVID symptoms. We've used in some instances of milder symptoms, low dose steroids, 5 milligrams of prednisone. And there was a great immunology professor at Northwestern named Roy Patterson, no relation. We were there at the same time, and he swore we were related. I said, don't say that, because they'll think that's how I got into Northwestern, and I don't want my parents to think that there was a connection. I'm just joking about that, but we were close. And but he published 800 papers in immunology, and he gave every asthmatic 5 milligrams of prednisone for their entire life. Absolutely no side effects, but extremely effective at tempering the immune response. And so, yes, there are instances where we still use low dose steroids, always in combination with ivermectin, combination with statins, and it has been effective in individuals who don't have significant vascular inflammation, or don't have maybe some of these other mechanisms at play, but just have some residual inflammation that needs to be taken care of.
And so finally, if you had infinite resources and could design a research project that would excite you the most in terms of answering the questions that are bothering you the most at the moment about long COVID, what would that research project be?
I think, for right now, we have a pretty good handle on a precision medicine approach to diagnosing, treating, and managing long COVID. The one big question which you brought up earlier, which is very important, was, are we creating more long haulers? I mean, when you think about the fact that it could be 10 to 30% or even more of everybody who has had COVID, I mean, now that there's over 150 million, I mean, you're talking about somewhere around 15 to 50 million people who will have long COVID. And frankly, we need to figure out why they are getting it. So I think if I had infinite resources, I would be looking into the why. And a lot of that might be just demographic and research, and looking back at charts, and how the patients were managed, and what was the presentation then. So I don't know that it would be that difficult, but I think knowing what is creating or setting up somebody for long COVID, or maybe we can't avoid it. I think that has to be looked at, or else we're going to be faced with 5 years or maybe even longer of treating long COVID. So that's what I would like to do.
Yeah. Okay. Well, thank you so much for your time, Bruce. Thank you for everything that you've done in terms of helping our understanding globally about this condition. It's hugely important. And I look forward to seeing your paper. Do you know when it's going to go to preprint?
The second one should go to preprint in a week or so.
Okay.
We keep adding elements that make it better, and then but the first one about the bioinformatics will be out really, really soon. So I'm really excited about it. And then, of course, the third paper will be looking at whether or not there's replication competence in the cells that we're able to sort that contain protein. So that's our path forward in terms of publications, and we're not going to stop working until we get this thing figured out. So I appreciate the time and and the friendship. So we'll keep working.
So obviously there are still some huge questions for long haulers. Is there a reservoir of viable reproducing virus somewhere in the body that's spitting out this debris for the monocytes to clear up? If so, how do we get rid of it? And what are the implications for recovery? And unfortunately, not every country has the ability to prescribe the medications that Dr. Patterson recommends, outside of a clinical trial, that is. So for people in those countries like the UK, might there be something we can do to manage the immune response and autonomic dysfunction, rather than have to attack the trigger itself? More on that in some of the next films in this series. Till next time.